Yeah, good evening, everyone. Myself, Dr. Raghu, working as HOD Emergency Department at Yashoda Hospital, Malakpet. So every Friday, we bring interesting, relevant, and up-to-date topics in the field of emergency medicine presented by our experts. So this week, the topic is new guidelines on the ATLS. So we will be discussing about the 11th edition of ATLS, which was released in 2025. So, to discuss this topic, we have the speaker, Dr. Tejasvi Chikatla, who has joined as a senior consultant head of the HOD Department of Emergency Medicine at Yashoda Hospital, High Tech City. So, I'll just give a brief introduction about this topic. So, this topic about the recent guidelines ATLS, so they have brought some changes, about 5 or 6 major changes in the ATLS guidelines. So the first is previously till date we used to know that we uh, we have only the ABCDE. So the changing of the fundamental from ABCDE to the mnemonic of XABCDE. So the revision of the prioritizing the immediate control of the catastrophic bleeding. So over the airway management in specific causes. So like this, there are several number of recent changes. So to discuss this, I'll the speaker, Dr. Tejasvi Chikatla, will be talking. So over to Tejasvi.
Uh, Thanks, Dr. Hussain, for the introduction and giving me a brief insight of ATLS updates. I am Dr. Tejasvi, the consultant and head of department at Yashoda Hospital, High Tech City. Why we need ATLS is important for us is ATLS is such a way that it's bread and butter for every emergency physician to handle the trauma patients. Without the ATLS, we won't be able to deal with the trauma patients in an appropriate manner. As the latest recent edition of ATLS updates, so important is the only more tragic thing is death that could be prevented. If the death happens, which can be prevented, and even after doing everything, then it is unavoidable thing. More important, we need to avoid things, do in a systematic manner to avoid death in the trauma patients. So ATLS 11th edition introduces radical shift in the trauma management. It primarily focuses on damage control resuscitation. These are the important updates where we need to concentrate on. There are core protocols which has been updated. There's airway and breathing changes have been done. The circulatory and resuscitation, there are few changes. The neurological and spine care, which has been interlinked together. There is a new thing added is resuscitation team function and communication. There are a few other chapters which has been added to the new curricular concepts. The core protocols, main important aspects in the primary survey, which was ABCDE before. Now it is changed to XABCDE, where the X angiovenous bleed, the prioritization immediate to the control of life-threatening external hemorrhage before the airway. As we know that before we used to start with the airway, now it has been changed to the exsanguinous bleed. If there's a artery cut or artery spurt which is happening, so our concentration goes more towards that. Resuscitate first the bleed control, then we go to the airway here. The next interventions which have been new updates are the use of direct pressure, wound packing, and early tourniquet application and the wound management. And the use of tranexamic acid, that's a standard recommendation to be administered within 3 hours of injury for bleeding shock. It started with the loading dose of 1 gram and followed by the infusion over 8 hours. And the airway and breathing updates are contextual airway management, emphasize on drug-assisted intubation or a modified RSI tailored to the patient physiological status. As we usually do, the trauma patient who are unconscious or who have airway threat, we usually go into the RSI without stabilizing the patient. Here, new guidelines emphasize that we have to resuscitate first, emphasize or maintain the drug-assisted intubation and use the pre-anesthetic medications in use, induction and paralytic agent, then we need to go for the intubation. And resuscitation before intubation, as I said, it is more important. We have to resuscitate first, the exsanguinous bleed, control the bleed. We have to prevent the shock. Then we to avoid cardiac arrest. So that induction agent before administering. So this is a more important aspect to prevent cardiac arrest in trauma patients. And other important aspects in the breathing is the needle decompression. As in 2020 guidelines, they said second intercostal space and the fifth intercostal space. As in 2015 guidelines, they said second intercostal space. Now it is changed to second as well as fifth intercostal space. Two things have been considered now. And the second intercostal space more in the pediatric age group and as well as in the adult age group as well. Whereas the fifth to sixth intercostal space anterior to anterior axial line, which is there previously and has been continued now as well. And more important aspect in the airway management, whereas we have in trauma patient where the facial fractures, facial deformity, and as well as the blood which causes difficult airway. So use of video laryngoscopy at the ATLS is important aspect which has been added recently. The circulation resuscitation updates comes to the fluids. It is restricted to the 1 liter, whereas previously it is 2015-20. It's up to 2 liters it was, but now it is restricted to only maximum of 1 liter. Do not exceed more than 1 liter. Instead, we need to use blood transfusion where balanced component therapy need to be used, or we can use the whole blood. Whereas the balanced therapy is massive transfusion protocol we need to activate, where 1:1 ratio of packed RBCs, fresh frozen plasma, and platelets need to be transferred at the earliest in a massive bleed who has hemorrhagic shock. And we also maintain the pervasive hypotension. The target systolic blood pressure is 80 to 90 in a penetrating torso trauma until bleeding is controlled. Whereas in a traumatic brain injury, we need to maintain about systolic blood pressure higher, that is 100 to 110 millimeters of mercury. When it comes to the neurological and spine care updates, there are two things which has been added here. One is head and spine injuries are now combined into a single disability chapter to emphasize the clinical overlap, where it's not separated now, it's included together, and emphasizes more on the traumatic brain injury care. As I said, the higher blood pressure goals and prompt anticausal reversal. Along with here, previously we concentrated only on hypocarbia. Now we need to concentrate more on hypo and hypercarbia. We have to prevent both here, and we need to maintain normocarbia. Whereas spinal motion restriction, this has been shifted from immobilization of cervical spine to selective spine motion restriction, advising judicious of collars based on clinical evidence. Some minor road traffic accidents where you don't need to go for cadence spine rule or next area, then depends on that, you need to put the spinal motion restriction. The new thing which is added here is the resuscitation team function and communication, which is most important aspects. As you might have seen in the ATLS resuscitation, the team approach is very predominant, and team lead role and that part of the team is more important. Where the previous ATLS guidelines, there is a vertical approach. Now it is a horizontal approach. The team resuscitation is more important. Team roles and leadership. The trauma team leader directs care and delegates tasks. Use closed loop communication, maintain shared mental model. Effective leadership, attention, situational awareness, decision making, communication, and task coordination are the key for a high functioning team. These are very important. Without the team coordination, it's very difficult to resuscitate a trauma patient where one person takes care of the airway, other person takes care of the breathing, other person takes care of circulation and the scribe. So these are the important role where you need to have a team role here. And the communication with the handovers. Communication is more important not only during handover, during the resuscitation as well. They use a MIST model to communicate with the pre-EMS, pre-hospital care, and as well as the emergency department handovers. And along with that, we use SBAR handover. Now they changed to SBAR to XABCDE bar, used for transferring out or between the teams, as well as from the emergency department to the your intensive care unit or to the specialist consultations. And along with that, they have added patient and family education. We need to use simple language when communicating with the patient family or patient to the patient who's conscious oriented, or else the patient family members. Empathetic way, and should be very clear. You should use the cultural and the language needs if required. Use a translator in case of there's a language barriers as well. Use of social worker and chaplain when needed, which is more important. And the last, the new curricular concepts, the trauma system, and your dedicated chapter focused on inclusive trauma systems, that is the triage, disaster preparedness, and mass causality principles. which is more important. Recent times, we have seen a lot of disasters happening. There's a bomb blast. There's a war between Iran and Israel is happening. There's a lot of mass casualties have been there. And also recent, we have the India-Pakistan war. Even there also in the Kashmir, we had a lot of mass casualties. So we need to be prepared enough. And in India, so there is a lot of building collapses. There is a lot of accidents, road traffic accidents, where this bus accident with the lorry, there are a lot of patients will be there, or 30 to 40 patients, or some hundreds of patients will be involved. So we need to prepare. How to prepare for disaster is included in this now. And the special populations, we need to concentrate on the elderly. We should concentrate on the pediatric age group and also the obstetric group. Here they have calculated the frailty index rather than just going the chronological age for geriatric patients, and more concerning the polypharmacy, where drug interactions will be more concerned on, and also the patient will be on heart failure or blood, where the resuscitation is more predominant in the, and think of reversal. Sorry. Yeah, and we should think on the reversal agents in the hemorrhagic shocks. So it's more concentrating on the polypharmacy in such situations. And the special pediatric equipment doses need to be calculated, and the checklist has been created accordingly. And the dedicated pediatric obstetric toolkit during the resuscitation of obstetric patients, they have formed a pediatric obstetric toolkit, which is available in the manual as well as in the recent guideline updates. New content areas where they're more concentrated and they added the new chapters are injury prevention, trauma-informed care, and penetrating trauma. And also they have aligns the civilian ATLS with the military tactile combat casualty care practices, which is more important. Where March casualty disaster, this is more useful tool which can be practiced. These are my references, which I got it from ATLS 1137 course manual and the recent educational updates. And at the end, I'm one of the ATLS faculty. So I've got the new update guidelines directly from the ATLS, American College of Surgeons, which I've done my certification. So I was up to date right now. And every emergency physicians, it's important for us to get an up to date on the ATLS so that we have resuscitated a patient and saved lives. Thank you. I think I went very quick, and this was important updates. There are a lot of things we need to add on. Just go through the ATLS manual and you'll find a lot of important aspects now. And the ATLS courses of 11th edition is not yet started, and they're going to start by next month. Thank you.
Yeah, to continue this, so we all know trauma is an important thing to be addressed as early as possible. So for this, we have the first platinum 10 minutes where the on-scene pre-hospital care has to be initiated, and there should be a rapid transportation to the nearby hospital. Or the other thing is a golden hour where the patient from the on-scene to the emergency department, where the patient has to be again resuscitated, and if required other transportation. And recently we had the budget of by the finance minister saying that they're releasing funds for the pre-hospital care and developing the ambulances services and the trauma care for all the civilians. So which is a heartening welcome message from the government of India, which is initiated. So to this to come into and implement, it may take some time. So Yashoda Hospital, they have a tie-up with along with Apollo Hospital in the ORR. So they take the all the ORR patients, the trauma patients to some get diverted to Yashoda Hospital, High Tech City, and some get diverted to Yashoda Hospital, Secunderabad. So by this, Yashoda Hospital is doing a pre-hospital care on the ORR. So any questions, Dr. Tejashvi will be ready to take. Anything from you, Tejashvi, or shall we wind it up?
I think we can wind it up.
Okay. So if there are no questions, so we'll come to the end of the session. So every week, Yashoda hospitals, they come with a webinar which includes faculty from the senior most. So bringing up the latest updates for the residents, junior residents, the SRs and assistant professors and the faculty. So if there are no questions, so we will wind up and wait for the next week.
Yes.
Okay.
Thank you.
Yeah.